He gave an hour talk to us when we were residents. It was a very impromptu thing on a Thursday morning at PI that was one of the more inspiring moments I've ever had in my career. It's probably something, I know he doesn't remember it because we've discussed it. But he has a capacity, Les has the capacity to energize an experience and make it real that very few people have. And I think that this gets to one of the questions about managed care treatment. The average managed care psychotherapeutic contact will be under medication management for psychiatrists. So they'll be paying for the pill part of it. They'll call it medication management. But that doesn't mean we have to accept that idea. The real therapy we'll be doing in life is during those 20 minutes. A very good friend of mine from Japan, Yutaka Ono, had to go home before this meeting today, wrote an article called Zen and the Art of Psychotherapy. It's a brilliant article. And he likens the situation in Japan is they have 1/8 the number of psychiatrists we have, almost no social workers, no psychologists, and half the population. The insurance system pays them $30 for a session, whether it takes 10 minutes or an hour. There's a psychoanalytic movement, but most people are seen for 10-minute sessions because you get paid the same for 10 minutes. It's 20 minutes, people being what they are. Most people are seen for 10 minutes, even by the psychoanalyst. The point of the article was to, one of the major high points of the article was to liken the 10-minute session with the Japanese tea ceremony. Now, I've been to Japan a couple of times. I've hated the tea ceremony because I like to eat the food, and I missed the point. But he explained the point to me. This was devised 150 years ago. It's a recent thing. And the idea of the tea ceremony, the word is Ishigu Imichi, I think. And the idea is something like whole life in one moment. And the reason it takes a while to get to the tea is to somehow or other ennoble that experience of the tea pouring. Not to have it just be, let's have some tea, which is the way I usually do things, but rather there's something special happening here between us. And let's never forget that this tea is special, that the world has a spiritual meaning beyond the fluid that we're drinking, and that you and I are sort of isolated in this wonderful moment where we're sharing it. And he likens this to what we have to learn to do in 10 minutes. And I think that that's a brilliant, very inspiring, it's a Leston Havens kind of inspiration that I got when I read that paper. Les punctures scientific humbug, and there's a tremendous amount of scientific humbug in our field. There's obviously been a remarkable neuroscience revolution. If you see the pictures, PET scan pictures, receptor pictures, it's absolutely miraculous. Has almost no implication for clinical practice now. And people who say that they can tell which receptor they're tweaking with the medications are full of it. I think that at this point, the neuroscience will take years before it actually informs in some clear-cut, believable way. And it may never do it because there are just too many transmitters. And there are too many different kinds of receptors, and it gets very complicated. And it's just very hard to be linear in the determinism. The clinical research literature has also been oversold because it's always studied the simplest problems. And it comes up with very simple answers, and most patients who get into studies would never be seen in your offices because the people we see have more complex problems. And the harder questions don't get studied because they're too hard to deal with in studies that can be interpreted. So a lot of what we do is art. I mean, I think that the better we realize that, the more effective we'll be, and I think Les is one of those artists. What he's tried to do today is convey some of his art. He's trying to put that, sort of like Picasso telling you how he paints. And Les is better at doing it than describing it. Partly because it's impossible to describe, and partly because you probably can't train another person to do it. So when people ask the question, how reliable would this be in other people's hands, the answer is clear. It would be lousy in everyone's hands, except his. That we would be approximations of and he's shaking his head with typical, the poor guy doesn't really appreciate himself, but nobody's perfect. He doesn't realize that what he does is not something other people can just take off the shelf and do themselves. You can learn from it. You can get better learning from it. You can get worse learning from it, depending on what your style is to start with. But you certainly can't do it his way. And I think there's a certain inherent lack of science in the therapeutic relationship that we shouldn't be too ashamed of. There are things you can study scientifically, other things that are hard. Empathy can't be bottled. It can't be taught. It's one of the sad things, that you have it or you don't, I think. People can sometimes curb some of the rough edges, but it's not easy. Then we get to Peter. I think Peter's the person I would disagree with the most, and so it'll make for, the things that the first two guys said, I don't have much to really take issue with. But with Peter, we get into a little bit of a back and forth. Peter's worried about a world that's theory poor. And I wish we had a world that was theory poor. I crave a world that's theory poor. The problem is we have lots of theories, have too many theories. And the idea that there will be a good theory, I just epistemologically work that way or have hopes that way. So I wish we had, James, to paraphrase Joyce to his detriment, theories are big words that cause so much confusion. And I think we'd be better if we could just get away from a lot of theories. Darwin, who Peter mentioned a couple of times, and who, by the way, is the father of psychodynamic thinking. I think Freud was a good Darwinist, and Freud at his best moments was learning from Darwin, not from Helmholtz. In his best moments, he was an evolutionary thinker in psychology, not a metapsychologist trying to fit physical theories into a metaphor that didn't work very well. But to make a long story short, Darwin said something about, if you want to learn about things, look at baboons. Don't read philosophers. And if you want to learn about people, probably reading metapsychology or trying to develop a new grand metapsychological theory to help inform clinical practice, that would be the worst thing in the world, I think, to do. I think it would be a wasted effort. I think if people study it a lot, they'll be worse therapists. I sometimes tell patients, and even more often tell residents, to be a mammal. That, mammals are good. Mammals know what to do most of the time. The things that come to you naturally and interpersonally and that work well, you can't really be taught. And if you get too theoretical trying to figure out what's going on, it may make you worse. I think the false memory issue is a terrific example of a confusion that actually did start with Freud and Breuer's interpretation of the early material. Is it true? Is it not true? Back and forth, historical accuracy, who cares? I mean, ultimately, who really cares? Will it matter if it's true or not? Will we ever know? Probably not. Epistemologically, I think it's impossible. Practically, I don't think it helps a whole lot. And there are important things to figure out about a person who's worried about that. There are important steps to take next. But trying to find out the truth isn't, in my opinion, one of them. What this leads to is not a theoretical sort of interest, not which therapy is better than which other therapy or what's the theoretical underpinning of this or that, but rather something that's much more like the other work in the field that's been most important in my understanding of what I do, and that was the book Persuasion and Healing that's recently been revised, but that Jerome Frank wrote, I guess it's almost 30 years, which ages us, 30 years ago. And he took the view of a Martian to the therapy experience and said, what's going on here? And he found a lot of very traditional things going on. People talked to one another in a magic circle where both the therapist and the patient thought something good was going to happen. There was a magical exchange, a ritual that was performed. They both felt that they understood what was happening, and the person was given permission to go off and be better, remoralized. And I think that, by and large, the psychotherapy outcome literature confirms the belief, or at least it doesn't disconfirm the belief, that that's what counts in therapy. That the different treatments all do pretty well. They all do very well compared to drugs. The psychotherapy works. But none of them probably works the way people think they work when they're doing the model. That that this fancy cognitive technique worked with the interpretation, or that the extensive, precious, let's figure out exactly what all this means is probably much less important than the being a mammal and a shaman in the interaction. And that if we could only bottle that better and worry more about that and protect that from managed care, not giving us the 20 minutes to do it, that would be more important than trying to come up with a grand unified theory about what it all means. Peter Wyden presents a down-to-earth, I think, very useful model of work with psychotic patients, but the model is not really that different for any patient. The only thing I would challenge in what he says is the idea that there's psychoeducation and there's psychotherapy. Part of this be a mammal, common sense, interpersonal relatedness with patients is education. Education, something that mammals do, and that seems to be something that helps them, and that birds do, by the way, and that it's not restricted to mammals.
And bees.
Do bees actually bees do educate, don't they? What was your association? This is a cold. Aren't you too young to know Cole Porter? Birds do it, bees do it, even. Educated, please do it. It fits. The whole thing fits. So that imparting information, intuition, caring support, advice, attention, hope, a little bit of magic, normalizing. All of these are part of psychotherapy. They're all part of education. They'll be done differently depending on what the other person's like. And I'm not sure the label helps that much. So that being schizophrenic, I'm not sure what that means. I don't think it means a whole lot. It means certain things that you're not, but there, as someone suggested, maybe 15 different things it may mean that you are. The psychoeducation for, quote, schizophrenia probably is going to be manualized. And it's good to have manuals. On the other hand, it would have to be tailored to each individual patient, because being schizophrenic doesn't predict a lot about what the other person will be like in the room. And I'm not sure you can manualize the interpersonal sensitivity, that that's what you're born with. And you can, I think when Peter says don't look hard at a schizophrenic patient, that's good. You can learn from that. So that not all learning is bad, but if you get too complex about what's going on, you may become more inhibited than is useful. So the summary of my reaction to a very interesting day is that we're under grave threat to be able to be good doctors. And that grave threat is across not just our profession, but all of medicine. That the average primary care physician is doing 6,500 visits a year and seeing patients for 7 minutes. The average psychiatrist pretty soon will be seeing patients for 20 minutes. In Japan, they're seeing them for 10 minutes. And somehow or other, that's going to be harder for those of us who trained a different model than the younger people, because this is what they'll know. Somehow or other, to make that precious, to get the tea ceremony kind of spirituality about the contact, to not see it as being routine. It's routine for us because we see a lot of patients. It's not routine for the patient because they don't come to see us very often. And whether they see us for 10 minutes or for 20 minutes or 4 times a week for 45 minutes, that doesn't necessarily determine what happens. Getting the patient's attention is crucial, and I've had the experience of treating people for many years and never getting their attention, and having absolutely zero impact after, in some cases, 10, 12, 14 years of treatment. Zero impact. They would have been exactly the same if I didn't exist. I've had the other experience of people coming up to me years later saying, you said this to me in the emergency room. I don't remember them, I don't remember the moment, and it changed my life. So the idea that it's something that's linearly related to the number of minutes or to the technique, I don't think it works that way. There's something magical that sometimes happens, and our job is to make that magic happen as predictably as often as possible.
Comments from the floor?
Reference on that paper, please.
Yeah. Why don't we bring all the panelists up? Come on, they're resisting. They don't want to be up here with this big mammal.
There's a chair for you. There are enough chairs. You can't count anymore? She told me she didn't have enough room.
Comments?
I'd like to ask Dr. Francis or anybody else, is there any evidence or data about psychotherapy or psychoanalysis in Canada? And does the magic that you describe happen better in healthcare systems that treat healthcare as a social good, not a commodity?
I'm not sure I can answer that, and other people may be better at it. Generally, countries that allow a lot of psychotherapy have very few, a lot of, quotes, analytic type therapies have very few people doing it. So the minute you have a lot of people who want to do it, that becomes an obvious cost target.
There's some interesting epidemiologic data about treated mental illness in Ottawa, which is big enough, in Ontario, which is a big enough part of Canada to represent much of Canada. They have fewer psychiatrists per capita than the United States, and fewer other mental health professionals. But the chances of a seriously ill patient getting psychiatric treatment or psychotherapy are greater than in the United States. The chances of somebody with minimal illness or dysfunction getting treatment are much, much higher in the United States. So it's a system that tends to triage treatment toward those in greatest need, in contrast to our system, which triages treatment toward those with greatest desire. who usually aren't those with greatest need.
Over here.
Dr. Francis, you seem to value psychotherapy and you call it an art, you say a lot of it is art. And looking at psychotherapy research, a lot of it's rather cumbersome. It measures outcomes of psychotherapies that are not very widely practiced in the United States. And I'm just wondering what do you think the right strategy should be? Should we as a field say this is not subject to scientific rigor and measurement and accept that or not, or should we try to kind of fall over ourselves trying to prove something that is not really scientifically testable?
Well, I think that the psychotherapy outcome is scientifically testable, and the clinical trials methodology can be applied to it. Process is not testable. I think that the great results we have are that psychotherapy works for mild to moderate conditions of various sorts, and that different psychotherapies work so that we have an arsenal of different treatments. I mean, no one criticizes the fact that there are 19 now probably 26 antidepressants that work. It's good to have lots of psychotherapies that work. It gives people a wide array. That literature is precious. The problem is that we're living in a bubble in time that's really crazy, where the decisions are being made by people who have absolutely no awareness of the literature and no interest. That the ears of the benefits managers are in the hands of the accountants from the insurance industry and their physician lackeys. And that at this point, it's not at all, people don't even know about cognitive therapy. People making decisions haven't even explored that literature. Now, in a few years, when there's very little money left, it's going to be turned back to us. So once the money's drained out of it, the providers will be doing things. And this literature will be useful to have. It'll help make discriminations. It'll make for more specific treatments. It's a good literature to have. It's just temporarily it's not being used.
I don't know how much time you want to spend on this level of pragmatism, given how much interesting theory we've heard. But just in response to that particular question, it was a wonderful title of a paper by Morris Parloff, which many of you may have read a few years ago, called something like Psychotherapy Outcome Research Meets Public Policy, Bambi Meets Godzilla. And I would say there's another problem, however, which is that the psychotherapy outcome literature, particularly as it compares to therapies, is just terrible. It's shameful literature in a certain sense, and I know this is not a universally held view, but we're having an enormous discussion about something of no intellectual validity, in my opinion. Just to give the least critique of it, the model for psychotherapy outcome is to set aside $14 billion, I wish, it's $14 million, and you take two therapies, you define two therapies which no one has ever used. You then train people to do these therapies through unvalidatable training programs. You then observe people to see whether they've done the therapy and throw out, the inspired therapists who manage to fit the treatment to the situation and are not doing the therapy. And then you look at dubious outcome measures over doubtful periods of time. And if you were, without knowing anything about the active ingredient or the dose response curve, if you were a pharmacologist trying to get your master's degree using a method like this, you'd be thrown out of the program. And what is particularly difficult is with not knowing the active ingredient is that if it is the case, for example, that a particular training program, set of training programs, decreases the confidence of the therapist, and in therapy A, decreasing the confidence makes very little difference, and in therapy B, it makes an enormous difference. In the end, you get some kind of differential response, and that differential response has nothing to do with the efficacy of the therapy, which wasn't a real therapy anyway, but has to do with some hidden elasticity of the treatment with regard to some effect of the treatment program. And it is incomprehensible to me that the field bases its quest for reimbursement on this sort of evidence, other than that we were lucky it came out sort of generally positive.
Everything that Peter says is true, but I think he misses the purpose of the studies. If the studies had turned out negative, that would be the first paragraph of the rebuttal argument from the psychotherapists explaining why psychotherapy shouldn't be dismissed because of this negative study. But when you're doing a first round, quick, dirty research project, you load everything against you so that a positive answer means something. What the studies have demonstrated is there's a pony in there. They don't tell you how to do therapy. They do tell you that it's impossible to dismiss this mode of treatment, even when given the toughest possible methodologic barrier to pass, which is being judged as though it were a drug against the condition for which drugs are most effective in circumstances that were idealized to show the drugs worked. In spite of that, it matched the drugs. That means you can't dismiss it. It doesn't tell you anything about it. It was terrible research for learning about psychotherapy, but it was superb research for demonstrating it was worth learning about psychotherapy. Peter, who was a central figure in formulating the federal government's policy in this area in another era, is of course responsible for not having the resources to do the right kind of research.
We'll take another comment from the floor.
I think that shows the need to actually do some more development of theory. Despite what Dr. Francis says, I think the problem with theory is just there's so many epicycles now, and theory ultimately is just beliefs, and you got to believe something to orient you to where you're going. I think the demoralizing thing that the research so far about psychotherapy outcomes has had is that they say any psychotherapy in competent hands works, even though each of these therapies often say the other ones shouldn't work, which really comes down to saying it doesn't matter what religion you believe in, but you've got to believe in one. Now here's where you need somebody theoretical to come in and straighten out that mess, because you can't really obey that particular commandment.
I don't think the current research shows any therapy works. It shows that our current research is unable to differentiate the effects of the different therapies. But if you look at the power of the studies that have been done, sizable differences would not have been detected. So we know the differences are not so huge that the strategies that have been used so far would have detected them. Frankly, it would have been astonishing if they had. I think the answer is we don't have empiric data on that question. Dr. Francis mentioned a wonderful book by Jerome Frank of a few decades ago, where he argued, as you suggest, that it's very important that the therapist believe in the theory, because otherwise the therapist doesn't have the conviction and the power that he would have, but it doesn't make any difference whether the theory is true or not. That's also a testable hypothesis. We could have therapists doing therapies they don't believe in and see whether they can be convincing and effective while doing them. But we don't have those answers yet. All we know is that therapy works. We don't know which therapies work.
Over here.
It's a little bit off topic, but can you guys comment on what you think about time-limited psychotherapy?
What was the question?
Comment on what you think of time-limited psychotherapy. Is that directed at anyone in particular?
Well, everyone has been talking about studies of psychotherapy, and no one has mentioned the Consumers Report study, or Martin Seligman's brilliant comparison of the Consumer Report survey with the kinds of studies that have been discussed so far. And many of his remarks have been actually echoed here. But the Consumers Report study, which was a more naturalistic one, you remember, and allowed people to change therapists as they wished to and to stay as long as they wanted to, suggested that the longer you were in treatment with somebody you wanted to be in treatment with, and this remark was made earlier too, the longer you're in treatment with somebody with whom you like to be in treatment, the better you do. Now those are all self-evaluations, of course.
I can't just let that rest. I think practically speaking, we'll be lucky to do time-limited therapies. And I'm suggesting that medication management will be the major form of psychotherapy. So that's definitely time-limited. And I think we better get very good at it. And love it, and love doing it.
Over here.
Yes. This is something I inferred, and I'm not sure it's accurate. I thought maybe a couple of people mentioned something about a distinction between Axis 1 disorders that are major psychiatric disorders that really need to be treated, and problems in living which may be like Axis 2 disorders. And I just, you know, and I want to, it's something that I feel kind of angry about, because in a lot of the discussion now when they're talking about parity for mental illness, they're talking about Axis 1 disorders, and it seems like Axis 2 disorders, which are the ones for which psychotherapy is most effective, tend to be neglected, and yet they cause considerable distress among people who suffer from them and considerable cost to our society.
I don't know who wants to respond to that. This is not a relevant response to it. I just wanted to say that this pessimism about the public's interest in psychotherapy is just not reasonable. Psychotherapy is has been one of the fastest growing industries throughout the 20th century. Don't forget that psychotherapy didn't exist as a discipline much before the 1880s. It doesn't appear in the Oxford English Dictionary until then, and certainly didn't appear in America until then. But it has grown enormously rapidly without any kind of insurance support at all, for the most part. And we are entering, forgive my heavy prejudice here, we are entering a psychological age when more and more people, even in China, are asking the question, what's for me? And since they don't go as often as they used to the ancient religious places to get that answer, they come to us more and more. And not the most radical, managed care, greedy looter of our pockets, not the most efficient person of that kind is going to stop the growth of psychotherapy in America or in the world.
I'd like to say the same thing a little differently, which is that I think we as a field have to be wary about basing all of our discussions on hardy pragmatism or some constrained view of the future. I think part of our job, what the public wants from us, is to say, what is optimal treatment? And it's important that we be as honest as we can about that. Now, we have a problem because we have things like tradition, history, aesthetic sensibility, and so on, and these very limited outcome studies of limited treatments for limited indications to tell us what is optimal treatment. And I think that, it's all very well to say one can do without theory. All one needs, both sort of financially and intellectually, is pragmatism. Pragmatism usually, I forget there are wonderful quotes to this effect, but pragmatism usually is some corrupted form of some outdated theory. And I think that the contribution that we have to make is to say, how does the world look to us according to the most sophisticated perspective we can bring to bear on the problems in front of us? And that we can't avoid that question. We avoid that question at our peril. I want to shift the discussion a little you'll see this is actually rather related, by turning the discussion a little to Peter Wyden. There was a comment made by Christian Beals, I think, at the time of some of these negative schizophrenia studies. And he said that part of the problem is that the treatment of schizophrenia is really a lot like marriage, that it involves, if you're going to make an investment of what then was, and still sometimes is in very beautiful cases, the 10 years that you may be treating a very disturbed patient with all the medications in the armamentarium and a complicated treatment, you have to have some special resonance with the patient, and the patient has to have some special resonance with you, so that once you start things like random assignment, you've already defeated the possibility of this interaction coming to bear. In fact, maybe once you've started evaluating the person for the study, you've interfered with the process. So that I think finally there is some medical judgment, report of experience, and so on that's going to go on without the advantage of single or, God forbid, double-blindedness. I'm waiting for the study in which the therapist doesn't know whether he or she is giving the active ingredient in this arena.
I would like to go back to three of the previous speakers. I agree with Dr. Francis, who's fiercely pragmatic and time-limited in his scope, in thinking that there's not going to be a lot of medical, financial, economic, or organizational support for very much psychotherapy in the near future. I agree with Dr. Havens in that our culture and the trends of the last century make clear that psychotherapy will continue to be a growth industry, expected and demanded and received by the public, although in view of what Dr. Francis tells us, I think it's going to be largely extra-medical and removed from that frame around it as it becomes accepted in our culture in the same way that pre-kindergarten education is, or the Museum of Modern Art, and funded similarly. I think that in response to the question that triggered both of that, in my own mind, there are psychotherapies that are effective for Axis 1 disorders and are to be seen as analogous to other treatments effective for them. That for some Axis 2 disorders, psychotherapy is not a particularly good treatment, it's just the best treatment there is. I don't agree that it's very good, it usually isn't. I believe that the most common indication for it and where it's most valuable is usually in subclinical Axis 2 syndromes. I think that's the jargon of the day, but what I mean is people with personality characteristics that are maladaptive, although they don't reach the threshold for disorder diagnosis, but they're importantly limiting in their life. What are the situations in which subclinical Axis 2 syndromes are importantly limiting in life? Well, one of the major ones is people with Axis 1 disorders. So they end up being very valuable treatments for the rate-limiting aspects of personality that color one's ability to cope with, adapt to, and be rehabilitated from chronic Axis 1 disorders, along with other problems in life. That would be my notion of a problem in life. I think that's what Peter's talking about, Peter Wyden, who I think sees, if I understand him, psychotherapy as an extraordinarily important way in helping an individual cope with a chronic serious Axis 1 illness by maximizing their adaptive potential, by dealing with probably subclinical personality pathology in that person. Not that their Axis 1 disease is subclinical, but the personality features he's dealing with through his educational and other interventions are psychotherapeutic interventions for people who have very serious major illnesses. He's not treating schizophrenia in an attempt to cure it with psychotherapy as the misguided psychoanalytic attempts of the middle of the century were. He's treating the personality problems of patients who have schizophrenia to make them more successful people in spite of their schizophrenia.
Maybe I could also Dr. Francis for reminding us that psychotherapy is an art and that we are born therapists and that's why we do it. It reminds me of Edward Albee's lecture this morning. He writes plays because he is a born playwright. And if we continue, as Dr. Havens says, to do our art, we can do it well. Our patients will have the benefit, and so will we.
I agree with that. I want to make a comment. I mean, I agree with most of what Bob said, but I think the idea that medicine is not going to be interested in psychotherapy is dead wrong. And the reason I think that it's dead wrong is that medicine has to come to terms with our knowledge of the brain. They're going to be teaching about the real brain in medical schools from now on. And the real brain isn't the brain that the rest of us learned about. It's a plastic, extraordinarily self-healing, very complicated thing. And as the nature of the brain, which means the nature of the mind, becomes clear in medical schools, you're going to see a resurgence of a sophisticated interest in how you relate psychologically to patients, because you now can't escape it. Don't forget, the kind of brain that most of us learned about in medical school was a gray blob that was completed by the time you were born, or almost, and that couldn't change or repair itself, and no one knew what the extraordinary impact of the social environment on the very size and shape of that brain was until relatively recently. So because we now have a brain that is suitable for the mind, right, they can't take the mind out of the medical school anymore. And the reason that medicine has always, and I work in a medical school, and I don't mean to downgrade psychologists or social workers who've also made contributions, but the reason that a relatively small professional group, that is psychiatric type doctors and neurology type doctors, made such extraordinary contributions to the general development of psychology and psychotherapy, people like Freud, of course, notably, or Harry Sachs Sullivan, the reason they did that was they were very devoted, very smart, and very well trained in some of the related things to this, and that isn't going to stop.
Did you want to respond? In the back.
Yeah, I think that you're right, Dr. Havens, but I think Dr. Francis at the moment is right too. I think it's a political process, much more than we think. I think right now the bean counters have the floor, so to speak, and they are pressuring us in the direction that Dr. Francis says. I don't agree with Dr. Francis that we have to accept that and become 20-minute medication therapists. And this way I agree with you, but I think ultimately we have to become involved in the process so the high school graduate isn't making the decision, who doesn't know the literature. And that the more we become involved and the more we argue our position, the better off we'll be. One of my concerns about the panel overall in the past, even though it was much better in the discussion, is this sort of, I guess, psychotherapeutic nihilism, when we become too obsessional. This is where I agree with Dr. Francis. We become too obsessional, what we're doing right, what we're doing wrong, can we do it, we really don't do it, and we're really in terrible shape. And this doesn't look very good to the public. And I think we do know more. I think we don't know everything, and I think a lot of treatments do work, and they don't understand it totally. And we have to be very careful when we present an image to the public. The final comment about the Canadian system, which I always make, is that my understanding, I'm a Canadian, at least originally, I've lived here for a while, is that in Ontario, a whole group, although there are not enough therapists and there are not enough trained psychiatrists around, a whole new industry is developed of, I think they call them sort of general practice therapists. These are people, quite a few of them, I've met some of them, who, because of the fact that they have the medical system and you can only get therapy through the medical system, they don't pay social workers and psychologists, these people are general practitioners whose specialty is psychotherapy or talking to patients. And there are literally hundreds of these people who come up and they take courses in psychiatry, but they're basically doing a type of supportive therapy by and large. So there is an inherent need, and this is where I think you're right, Dr. Haynes. People want it when you give it to them. Part of the problem is in this country we have to convince people to spend their own money.
We have time for one more. We haven't heard from them, yeah.
Me?
Yep.
Yeah, just one of the models that we sort of have now is the psychiatrist conceiving his or her thing as the 10-minute medication session and referring to somebody else to do the psychotherapy. It sounds sort of like what people are saying is to reconceive of that 10 minutes or 20 minutes as a therapy session in a sense, so we should be less immediate to think that we have to refer somebody, say that we're giving, you know, some meds to do the therapy, like there has to be a 45-minute session every week. Is that kind of...
That's how I feel. I go out there and heal them.
Good.
Can I just follow up on that? Except for maybe a yearly course by Hamid or Davlu, I think we're not doing a very good job in bringing forward some of the new theories about sort of therapies, taking multiple generics and going on to the solution focus therapy. I wonder why that is true. Comment.
But first of all, I don't like the way he does short-term therapy. So
I'm talking about the other theories that are out there.
I think that there are lots of courses in short-term therapy. There's no shortage of them, and the one thing to be mindful of is that short-term therapy has been invented 50 different times in this century. Each person has a new fancy name for it. The elements are always the same. There's a focused treatment with an ending point, with the expectation the person is going to get better, with the expectation the person is going to do some work outside of the sessions, greater activity on the part of the patients and the therapist. It's really what Freud did first. This was Freud's therapy. When Freud's therapy was taken over by the analytic institutes, particularly in Berlin, they made it into a very bureaucratic, different kind of treatment with much more ambitious goals. Freud's original therapies have always been were in this mode, and the mode has been reinvented. And it's not mysterious, it's not hard to learn. Is it fun to do? It's terrific to do. And I think the major change now is applying some of those same techniques to quotes med management for psychiatrists.
I can't resist, since Davinlu's name came up, a comment that relates to something that was more part of the discussion than the talks. But I was asked to be a reviewer at one of these sessions a few years ago of a study out of Scandinavia of Davenlou's therapy versus supportive therapy for a group of patients. And so I got to really see the data. And that was, in particular, a study where one therapist's results were thrown out for doing what looked like, I guess, supportive therapy with patients she was supposed to be intensive with, and intensive therapy with the ones she was supposed to be supportive with, and she had the best results. You know, I think that... Enough said. Well, I mean, I think the conclusion is I would like to, if I were doing studies in this area, I would start with naturalistic studies of what works and try to understand what works rather than try to create artificial conditions in which we do less than the best we can do.
Could we have the reference of the tea ceremony paper you mentioned?
It's called Zen and the Art of Psychotherapy. It's in a journal I started, which has an interesting name in regard to Peter's comment about hardy pragmatism. It's called the Journal of Practical Psychiatry. I didn't call it the Journal of Theoretical Psychiatry. And I can send you a copy if you give me your thing.
Thank all of you very much. It's very stimulating.
That concludes this program. The material on this cassette was recorded and produced by Mobile Tape Company Incorporated of Valencia, California. More information about available cassettes may be obtained by calling 1-800-369-5718.